So yes, I had a chance to review the guidelines. Clearly they only became available this week, so I haven't been able to do a very deep dive. And my overall impression is largely consistent with the previous guidelines. They still stratify patients either outpatient or inpatient. In the outpatient setting, they provide treatment recommendations in the presence or absence of comorbid conditions like heart failure, renal disease, and things of that nature. And in the inpatient, they kind of stratify patient by hospital ward versus the ICU. And the ICU is, your typical ICU patients in, sepsis or septic shock. So across those different stratifications, there's a few differences. First, as I mentioned before, macrolide should not be used in monotherapy with regions with greater than 25% macrolide resistance in Streptococcus pneumoniae, which is the #1 cause of acute-acquired bacterial pneumonia. Unfortunately, we don't have a lot of good surveillance data with strep pneumo in the different regions. When we do look at it, most regions have 40%. So really, the guidelines indicate that macrolide should not be used alone, which is a new recommendation in contrast to the 2007. For patient with comorbidities, they recommend using beta-lactams or respiratory fluoroquinolone. However, although they make mention of some of the concerns with the fluoroquinolones within the guidelines, there's been a number of box warnings over the past few years. In years past, we had issues with QTC prolongation, tendinitis, and tendon rupture. More recently, they updated, the most recent update is, an increased risk of aortic aneurysm, particularly among patients with cardiac risk factors. So I think from that standpoint, we have a few different iterations, but largely the treatment choices are the same. Inpatient, it's still a beta-lactam with the macrolide or respiratory fluoroquinolone for your hospital ward patients. And for our critically ill patients in the ICU, it's a beta-lactam with a macrolide or a beta-lactam with a fluoroquinolone. They do discuss there appears to be some advantage in our ICU patients using a beta-lactam with a macrolide over a beta-lactam with fluoroquinolone. However, they said either one is an acceptable recommendation. Another big difference with the guidelines is the whole idea of HCAP. So actually, HCAP is a designation as healthcare associated pneumonia. This was from the previous ATS IDSA hospital-acquired pneumonia guidelines. So they make mention of this and said that this designation should be avoided, and rather what they added is treatment of acute-acquired pneumonia in patients at risk for MRSA or Pseudomonas aeruginosa. So what they did in this circumstance is, in someone who's at risk, prior Pseudomonas or MRSA infection or was colonized with MRSA or Pseudomonas, those individuals should be empirically treated if they're in septic shock, or if they have a positive culture at presentation among our hospital ward patients. So this is a recommendation primarily for your inpatients, because if patients do have risk factors for MRSA or Pseudomonas, those are the ones that tend to be admitted who have high acute disease severity. Interestingly, for our hospital ward patients, they indicated to only add MRSA or Pseudomonas coverage if that pathogen is identified. For MRSA, it could be PCR on NAIRS. For Pseudomonas on a clinical culture. So they only say in that circumstance, or the patient has a previous history of an MRSA or Pseudomonas infection. In that circumstance, if MRSA is previously recovered, to use vancomycin or linezolid. If Pseudomonas was previously identified, to consider an anti-Pseudomonal beta-lactam. And then again, those in septic shock, they recommend that they use those drugs empirically and de-escalate if possible if they're not recovered. So I think these are some of the biggest differences. Still largely the same, but they did provide greater clarity with that HCAP designation, which we all struggle with. They do mention about patients at risk for MRSA within a hospital. The risk of MRSA should be predicated on some validated institution-specific clinical prediction rules. They acknowledge those are not readily available. So this is something we'll need further clarification as we move forward in practice. So I think the biggest thing is if they had MRSA in the past, you should probably cover MRSA. Pseudomonas in the past, cover Pseudomonas. If you have it on a culture, Personally, I think I would probably cover them empirically and in a high-risk patient, perhaps coming from a nursing home or as a healthcare frequent flyer with a lot of prior antibiotic exposures. However, this recommendation that's made is in conflict for patients who are sick with pneumonia admitted but not treated within the ICU. So these are the patients without severe pneumonia.